Hello to all my colleagues and friends from around the world. It's a pleasure to join you in this format. I know that we have a few hundred of you joining from all across US, Europe, Asia, South America. Welcome, and it's a really nice way to wish you all Happy New Year. I hope this will be a great year for everyone, their families. We will have good health and peace. And it's my pleasure to discuss this topic that we have decided to cover today is periodontal and peri-implant plastic surgery with the Vista technique. So if you have any questions, I'll be happy to answer them for you, address them at the end. Please feel free to put in your questions into the Q&A of the Zoom at any point. I will make sure that I get to all of them before we finish. So let's get right to it. We have limited amount of time, and we're going to go through as much as we can cover in this period. So the idea is that in all of our clinical practices, there's so many scenarios where there's deficiency of soft tissue around teeth, around implant, extraction sockets, future implant sites. So trying to address these deficiencies is a really important clinical scenario that we need to address. And there are many different ways to address it. There are various techniques, various materials, various protocols. And I admit that I am biased in the way that I approach the subject. And there are many talented colleagues who have different concepts and still come up with outstanding results. But I would like to present you our concepts today. So the concept of mucogingival surgery is an old one that has been around for many decades, maybe more than half a century already. And the free gingival graft is one technique that seems to have endured. Still, many colleagues are practicing it routinely. It's a very effective technique for increasing the amount of keratinized gingiva, but it has many downsides. It is quite invasive in terms of harvesting large grafts, especially if we want to deal with a large area of deficiency, and it is not the most aesthetic technique. So as we can see from each of these techniques scenarios, we can see that the outcome is less than aesthetic. And one has to wonder, what is this really doing for the patient? Is there any benefit for managing the recession defect? Is there benefit for all the other teeth that have recession, have very thin phenotype, and at risk of recession? Or whenever this patient smiles, all that kind of comes out and is visible is this really ugly tire patch. And even this lady, very attractive young lady, has received a free gingival graft in the anterior area. And I hear many colleagues, they say they routinely use that. And I see on social media people posting proudly their free gingival graft cases. I don't question that this is a valid technique, but in my opinion, there are better techniques for managing that and that have many advantages. So we have kind of graduated beyond the mucogingival surgery to what is referred to as periodontal plastic surgery. So this transition is not just in semantics. It has to do with different techniques, refinement of techniques, in trying to pay attention to blood supply cellular wound healing and trying to optimize wound healing and blood supply during the surgery to allow for faster healing, for less patient morbidity, less scar formation, and considering what our patients view as the success of our procedures, I think periodontal plastic surgery definitely offers many advantages. But what are the techniques that are utilized for periodontal plastic surgery? Well, coronally advanced flap using a connective tissue graft may be considered the gold standard today. And what is the reason for that? Perhaps the reason is because of the volume of data that's available. It doesn't mean that this is the most effective, and history will show eventually when we have more data comparing various techniques. But because of the volume of the available data, this has been considered the gold standard. But when you're looking at these areas that have recession defects, the papillae in particular, that are therapeutic target, to cut the papillae, I think goes against many principles of plastic surgery. Plastic surgeons will never consider making incision directly in an area of therapeutic target. The concept of plastic surgery today is mostly about making remote incisions, tunneling toward the therapeutic target in an effort to try to preserve the blood supply of the therapeutic area and to try to minimize scar formation. So for that reason, the tunneling technique has been developed, and the first tunneling technique was the intrasulcular tunneling through the sulcus of the teeth. So this definitely has the advantage that there's no surface incision, so there's no scar formation, but it comes with many challenges. This technique is very difficult and challenging to execute because it works through a very small area to work through the sulcus. Very often, this is accompanied by a significant amount of trauma to the sulcus of the teeth, and also that trauma translates into diminution of the blood supply and possibly delayed healing, but also going through the sulcus of the teeth also has the limitation that in many areas you would not have enough of a release to be able to mobilize the tissues. So very often clinicians who are utilizing this technique are not able to fully coronally position the teeth. So many will tell you that, well, you don't really want to coronally position the teeth so much. And I think that's sometimes from not being able to coronally position, so they will tell you that, well, it's not advisable to coronally position. But I think that maximum coronal positioning is an important concept, and it's also important to be able to introduce graft material. So introducing a graft material through the sulci of the teeth, through a very small area, means that you are only limited to very small grafts to be introduced. But also sometimes people, to try to introduce the graft, cut the papillae. And that, to me, makes no sense, because you're basically, if you cut the papilla after kind of struggling to create that tunnel, then you cut the papilla. So what is really the difference between intrasulcular tunneling and coronally advanced flap? It's basically doing a coronally advanced flap, and then just means that in the beginning you went to the sulcus, but then later cut the papilla, just like a coronally advanced flap. So to me, that aspect does not make sense. So I will be the first one to tell you that I am biased for this next technique, which is the Vista technique. Vista stands for vestibular incision, subperiosteal tunnel access. So the concept is that the incision is made in the vestibule remotely from the therapeutic target, which are the gingival margins and the papillae, so that the blood supply of the therapeutic area is very well preserved. The area of incision does compromise the blood supply, but that compromised area is away from our therapeutic target, which is definitely advantageous. This is a very simple technique in terms of being able to execute for a large multi-recession defects. Most of our patients are multi-recession defects, and our concept of trying to address the main problem, which is a thin gingival phenotype, makes this technique conducive for changing the phenotype of the entire arch. So we view most of our cases today as full arch cases because most patients who have a thin phenotype, they're thin everywhere in that particular arch. So we try to manage the whole arch, and using the Vista technique makes it possible to go from one end to the other within minutes to create a tunnel that is mobilized, that is has a blood supply preserved, and it is conducive to insert large grafts and to be able to coronally position maximally with this technique. So many advantages. So, this is very good to, talk about my experience with this, but what is important is what does the data show. The systematic review that was conducted last year and was published in about a year and a half ago, compared various techniques of recession defect management, and it based on the available data, using the available data, comparing the Vista technique to intrasulcular tunneling, you can see that the studies that were considered in this publication, in this systematic review, none of the studies favored the tunneling technique, and every study favored the Vista technique. So altogether, there was a statistically significant, using the meta-analysis of the data, better outcomes with the Vista, particularly with a acellodermal matrix and connective tissue graft. There was a better outcome with Vista compared to the tunneling technique. Now, with the comparisons, there wasn't enough data between the coronally advanced flap and Vista, so hopefully more data is forthcoming. I am very heartened to see that all over the world there are many independent centers, universities, who are conducting research on the Vista technique, and I learn about these in publications, and I see every month publications coming out using the Vista technique and randomized controlled trials. So hopefully we will have more data comparing various techniques to have objective assessment. So this is a paper that actually questioned whether or not the connective tissue graft should be still considered the gold standard for management of gingival recession defect. Well, the concept is that, well, maybe based on the available data, you would consider connective tissue graft as the gold standard, but do we need to utilize the gold standard in every situation? So let's get into where connective tissue graft with a coronally advanced flap or other biomaterials may be usable. So as I've kind of referring to, our concepts have changed over the years. there definitely has been a paradigm shift in the way that we manage gingival recession therapy. We started out many years ago with putting keratinized gingiva at the center of our therapeutic focus, and that led to utilizing free gingival graft as a way of augmenting keratinized gingiva. So if you're really focused on lack of keratinized gingiva and the treatment that is being offered is a free gingival graft, then we may or may not be addressing all of the concern. One is if we're not really, changing the recession areas, achieving root coverage to the extent that's possible, maybe we're not addressing the patient's concern, but also phenotype modification, which is our current concept, is not being executed at the gingival margin, which matters the most. So many times the keratinized gingiva is augmented down into the vestibule. So there's deepening of the vestibule without trying to address the actual recession with this technique. So we have progressed from the consideration of keratinized gingiva being at the center of this topic of management to root coverage being at our focus. And root coverage is achievable in certain cases, such as this one, where we have the RT1 or Miller class 1 and 2 classifications with intact interdental tissues, favorable types of risk factors and indicators that are conducive to root coverage. But what if some of the situations such as this, where root coverage is not really possible because of interdental tissue loss and bone loss and position of the roots and various factors? Well, that has posed a dilemma. So if our main focus is root coverage, then we are failing in a significant percentage of our patients where root coverage is not achievable or not feasible. So we have progressed beyond root coverage being our primary outcome measure to considering the gingival phenotype as the primary outcome measure. Our goal is to increase the thickness of the gingiva, which basically changes the phenotype of the patient. We used to call this the biotype. Well, this term was changed, and the primary reason is that when you're talking about the biotype, it seems like something inherent that you're born with and you really cannot change, versus the phenotype is a physical characteristic that one may change. For example, my phenotype is one with white hair. I can change this phenotype if I want to, and I can dye my hair purple or whatever color, and I will have phenotype modification. Same is true when we're talking about the gingival thickness as constituting a phenotype, and we can perform gingival phenotype modification therapy as a way of changing the thickness of the gingiva. And that has been now the main focus of our treatment because of the predominance of the data that has suggested the importance of gingival phenotype on periodontal stability. In particular, it has been demonstrated that the stability of the gingival margin depends on the post-treatment gingival thickness that one creates. So if one can increase the gingival thickness after treatment, we can predict the stability of the treatment and the possibility of relapse or future recession occurrence. In fact, for every 1 millimeter that the gingival tissue is thickened during treatment, there is 0.71 millimeter less of future recession. So increasing the gingival thickness is our therapeutic goal, because by doing so, we can promote periodontal stability. So let's see if our goals, depending on the goals that we set for ourselves, what type of material are optimal for that. Well, if one's goal is to increase keratinized gingiva, then there's no question that connective tissue graft or pre-gingival graft, autogenous tissues are the most effective at increasing the band of keratinized gingiva compared to a cellulodermal matrix or collagen matrix or just coronally advanced flap. These are inducing minimum increase in keratinized gingiva. So the conclusion is that connective tissue graft has the greatest probability of complete root coverage, increasing keratinized tissue, better aesthetics, and stability of root coverage. So connective tissue graft is the gold standard. That's true. But again, the question is, do we need to utilize the gold standard in every situation? Because our therapeutic objective is also to increase gingival thickness. So if we want to promote gingival thickness gain, we can compare various biomaterials in terms of the ability to increase the gingival thickness, and we can see that connective tissue graft is essentially equivalent to a cellulodermal matrix or collagen matrix in increasing the gingival thickness. So these types of biomaterials have a very important role in terms of promoting thickness gain or phenotype modification. So these soft tissue substitutes have an effective role in increasing the gingival thickness, and they're very useful in our therapeutic strategy. They do not increase the keratinized tissue. So if your goal is keratinized tissue width gain, these are not the materials. But if our goal is phenotype modification to increase gingival thickness, these are valuable biomaterial to consider in our treatment. So to that end, I would like to highlight a case. At the Vista Institute, we hold training courses on the Vista technique. And at each of our courses, in addition to the didactic lectures and in addition to the hands-on workshops that we do, we always conduct a live surgery. So in our last Vista course, this was a patient on whom the Vista technique was performed. To illustrate the techniques, we find that participants really find a great deal of value in performing a live surgery demonstration. In that way, they could see, in real time, how much time does it take to perform the procedure, how do we manage the various challenges that may come up during each clinical scenario. So this is a patient with generalized recession defect. Now, what are the options that we have? Do you really have the option of a free gingival graft? Believe it or not, some colleagues still are doing that. They have the patient come in 6 different times, and they go through the palate and take multiple grafts each time and address 2 or 3 teeth at a time. Let's face it, no one wants to go through multiple procedures in this way. So what is the other option? Would you consider an intrasulcular tunneling? To me, to do that, it makes no rational sense to go through 14 teeth to make 14 different tunnels. It just does not make sense. So I think that the Vista technique has a distinct advantage that through limited access, we can address the entire arch in a single setting. Believe me, patients do not want to come back for repeated surgery. Okay? You know, doing a third of a sextant at a time, you may be, you know, a smaller surgery, but to patient, it's still a surgery, still a recovery, still having to show up for surgery with antibiotics, take time off from work, go through the recovery. After a couple of times, they don't want to come back. Okay? So most people appreciate addressing all of this in one single setting. So let's take you through our risk assessment. We will evaluate not only the surface mucosa, we will evaluate the bone, and we can usually find significant amount of dehiscence. And one of the questions is, do we only perform phenotype modification on the soft tissue, or do we also change the phenotype of the alveolar bone as well? Well, I can tell you there's very little data on changing the bone phenotype, but we do address that in our courses. And in this particular case, we address both the soft tissue as well as the bone dehiscences with bone augmentation, both through the Vista technique. But just due to the limited amount of time we have, I will just show you the soft tissue management of that during this case. So we start out by making a vestibular incision. I utilize this is a CO2 laser. You don't have to use a laser. It's just using the laser makes it less bloody, but you can utilize just a basic 15C blade as well. So after the vestibular incision, you have to decide which areas to make the incision. In this particular case, I made a midline incision. The midline is a very, convenient location to start the tunneling from. Now, granted that the central incisors had very little recession, even the lateral incisor had minor recession. So if that's all the patient had, of course, I would not be doing anything in this area. But if the patient has significant recession in the posterior areas on both sides, I might as well connect this because I can create harmony of the gingival margin. You don't want to create steps to coronally position the posteriors and anteriors remain long. So it's always one of the beauty of Vista is that you can control the position of the gingival margin. So in this case, I made the midline incision. I also made incisions in the premolar location to address the molar areas. So to harvest autogenous bone, we can utilize connective tissue graft. Now this is a little bit different technique of harvesting a connective tissue graft. I am de-epithelializing the gingival tissue from the palate. And this is a unconventional way of harvesting autogenous tissues. Because typically, when you make a connective tissue harvesting, there's a partial thickness incision in the palate, a flap is open on the palate, the subepithelial portion of the connective tissue is harvested. That really makes for a large harvesting area. The other technique is a de-epithelialized free gingival graft, which essentially is what we're doing. And de-epithelialized connective tissue grafts have the advantage that they are the more superficial lamina propria, which has better quality of connective tissue. Typically, you're advised not to take tissue from near the gingival margins because of potential risk for recession induction on the palate. But we find that if we harvest just a very small, narrow strips, generally maybe 2 to 3 millimeters of the palatal tissues of these teeth, and we actually are taking mostly the papillae of these teeth. You see that? The tissues are pretty thick in these areas, and you see, by going bilaterally, I harvested quite a bit of volume, but it's just at the gingival margin. So this technique is quite comfortable for the patient's recovery. You don't really have to suture the donor site. It's fast, effective, simple, and the concern about donor site recession is not really true because the donor site only has maybe 2 millimeters removed from it, and that area would granulate in within just a few days after. So we do not worry too much about the donor area. So connective tissue graft is extremely useful for root coverage. So we do utilize a very thin and narrow strip of connective tissue graft at the gingival margin. This is sutured inside of the vestibular tunnel using a lasso suturing technique. We will teach that. This looks complex. Believe me, every person who comes to our courses will learn how to make this type of suturing before they leave. The other aspect of the Vista technique is the bonding of the sutures that controls the gingival margin position and puts that in the control of the surgeon. But remember, our goal is to try to minimize our morbidity to the patient. So to do that, the morbidity is reduced by minimizing how much autogenous tissue is removed and augmenting and supplementing that with biomaterials. In this case, we're utilizing a cellulodermal matrix. This happens to be Alloderm Select. This is a prehydrated cellulodermal matrix that we utilize. It's a medium thickness, about 1.5 millimeters in thickness, and generally we use about 1 centimeter of that, and it goes through. So you can see I divided a 1 centimeter by 4 centimeters into 2 longitudinal pieces. Even though the packaging says 1 by 4, they're usually pretty generous, and they give you almost 2 centimeters of width. So you can cut it longitudinally. Generally, 1 piece is enough for the full arch. And you see we suture that inside the tunnel, and we don't need to suture every area of the dermis. We just suture the 2 ends, and if you kind of stretch that, it coronally positions it right under the gingival margin on both sides. And as we are making our sutures through, we are going through that. Now, I want you to see where the gingival margin is and where the CEJ is. We're going to overcorrect. Okay? We're going to overcorrect. Excuse me 1 second. I just need to remove this overlay for that I put in to show you where the tissue is. Okay, so we are next going to coronally position the gingival margins. Now this may seem like a complex procedure, but I can tell you that this is far easier than sling sutures. When you make sling suture, you're passing the suture interproximally from the buccal to the lingual, and you're using very small suture needles that are hard to pass through. But when we're using this technique, we are really only limiting our procedure to the buccal area, and we're basically placing a suture very simply that is coronally positioned and just bonded to each tooth at a time, one at a time, and we're overcorrecting. The gingival margin are positioned pretty much as the level of interproximal tissues. And this gives you as a surgeon full control of where the gingival margin is repositioned, and you're immobilizing the gingival margin. What is the significance of that? The significance is that you'll end up with a very harmonious gingival margin. And you don't leave that position up to the patient, because if it's up to the patient, they're going to go home, they're going to be talking, they're going to be eating, moving their muscles, and that moves the tissue up and down, and there's too much micromotion. Well, micromotion is the enemy of regeneration. If you're trying to regenerate bone, micromotion will form scars. If you're placing an implant, it will prevent osseointegration if there's micromotion. So why is it that micromotion has been considered acceptable for soft tissue grafting? It's not. Micromotion is as deleterious to soft tissue regeneration as it is to bone augmentation. So it is important that we also are stabilizing and avoiding micromotion during the healing of the soft tissues. And that can be effectively accomplished by immobilizing the gingival margin by suturing, bonding the sutures with composite. And lastly, we utilize biologics. An important biologic is PRF, platelet-rich fibrin, that we stuff inside the tunnel. It doesn't matter where you place it, you just want to stuff it in the tunnel, and that's going to promote faster healing, less morbidity. It improves the patient experience. So we are not really relying on this biologic for promoting better recession, although there's some limited data to suggest that PRF could assist with root coverage procedures, but I wouldn't count on it. I use the PRF primarily to reduce the patient's morbidity, reduce edema, reduce bruising, reduce the pain experience postoperatively, and accelerate the wound healing. So those are very good reasons to utilize this particular biologic, but also it's very cost effective. So it's a no-brainer to utilize it. So I want you to see how much we harmonize the gingival margins. You see that we basically brought all the mid-facial areas at the level of the interdental tissue, so we are overcorrecting. The sutures that we're using in the anterior area are clear sutures, monofilament, PGCL 6.0 diameter. The posteriors are the polypropylene 6.0. I ran out of the PGCL and I used a polypropylene at the end when this suture came out, because that's all I had there. But that's, so you can see the difference between the two. If you think that your patient will have a concern with the blue color showing, you could utilize the clear, although just so as you can imagine, it is more challenging to work with a completely clear suture. But the monofilament nature of PGCL is conducive to healing. You definitely want to use monofilament suture. Don't use too thick of a diameter. 5.0 is too thick, so 6.0 is very convenient to use. And polypropylene or PGCL, if you don't have access to those, nylon could be the next level substitute. So again, visualizing the overcorrection throughout the mouth. Also, you can see the palatal harvest area. We didn't have to suture that. It's just a very small area of exposure. I'm very excited about the new material that has become available for us called Elemental. This is a zinc-containing thermoplastic periodontal dressing. It's very convenient to form and mold into this area. So I'm very excited about this elemental. So in each of our courses at the Vista Institute, we'll be demonstrating its use in our workshop and live surgery cases. Okay, so you can see how much recession existed, primarily from the lateral incisor posteriorly, and how much overcorrection we did, and you see we have harmony throughout the arch. It's not one area or the other, it's just all one harmonious overcorrection. And when you're overcorrecting, you're going to have much better final result, a more harmonious and more aesthetic result. But also, one of the values of this suturing is that it creates a maximum thickness, because by coronally positioning and adapting the gingival margin in this way and pulling the areas that are more apical than that, what it does, it lifts the tissues away from the bone and creates a protective space. So you can appreciate how much of a thickness gain we have here. Okay, the suture typically creates a protected space that promotes maximum thickness gain. So you can see the amount of recession that we had and how much overcorrection we did. We brought the tissues way coronal to the CEJ. Typically, our aim is 2 to 3 millimeters coronal to the CEJ. And then this is the result that was achieved. You can see a very harmonious tissue level and, you know, more aesthetically pleasing appearance. And this is the best way to be able to address and to try to objectively evaluate our outcome. We can actually superimpose our intraoral scans before and after treatment. And when we superimpose these two, we can get a time-lapse view. You can see how much root coverage we have. And if you actually pay very close attention, you can see that the new location of the gingival margin is covering the CEJ. It's not to the CEJ, it's covering the CEJ, which is actually something that most people will not address for you, because the goal has been to reach to the CEJ. But we exceed that goal. So you can watch here and watch the gingival margin to see how much coronal to the CEJ we can bring the gingival margin. And we can see it's basically all around. And one of the phenomena that we see on a consistent basis is the phenomenon of creeping attachment. So actually during the healing process, we tend to see more and more coverage because we are creating so much thickness gain. So to evaluate the phenotype modification and thickness gain, you can appreciate when you look at the occlusal view how much thickness gain has been achieved. Now, some of our colleagues will say that is unaesthetic. Well, to me, what is very aesthetic and beautiful is periodontal stability. Periodontal stability is beautiful because you don't have to have a patient who comes back and says, well, your result did not work because it all went back. Okay? So stability is the most important aspect in this management. So the data shows that gingival thickness gain, okay, using just a coronally positioned flap is almost non-existing. But when we're using a cellular-dermal matrix, 0.4 millimeter can be achieved with, this is after 6 months of coronally advanced flap. Okay, so that is basically typically seen. Now, when we compare root coverage, okay, we have with coronally advanced flap by itself, 75%. when we combine coronally advanced flap plus dermal matrix, 95%. So you get better root coverage when we add the acellular dermal matrix. And also, when we're looking at complete root coverage, we can see that 83% complete root coverage compared to only 50% complete root coverage with coronally advanced flap alone. So it is better when you are coronally positioning the tissues to utilize biomaterial such as acellular dermal matrix to also mediate phenotype modification. Okay? Now, what do we know about phenotype modification using the Vista technique? Well, we have published a couple of papers on this topic where we compared our results with different material that was used in conjunction with Vista, either the lateral palate, tuberosity, dermal matrix, and collagen matrix. The average thickness gain in this retrospective analysis was about 1 millimeter, close to 1 millimeter. So the amount of thickness gain is really quite significant with Vista, better than other techniques, but it's not so dependent on the material because the Vista technique itself, because of this particular suturing, the suturing is the key. This particular type of suturing, by bonding the sutures coronally, it lifts the apical vestibular part of the tissue away from the bone and creates a space which is about 5 to 6 millimeters, and it's a protected, stable space that helps to promote maximum thickness gain. And this is the key why Vista works, and this is why the results of Vista are so stable over time, because we are promoting maximum thickness gain. This actually long-term outcome of thickness gain has been demonstrated by a study by Seiko Min, who is at the University of Texas in Houston. He has the longest term follow-up. This is 66 months of follow-up of phenotype modification at different levels at the gingival margin, 1 millimeter, 2, 3, 5 millimeters relative to the gingival margin. And you can see that what was achieved within 6 months is pretty stable over the course of a 66-month follow-up. And you have a very nice stability of that thickness that was gained with Vista. So we have many cases such as this. You can see that we are achieving root coverage. You can see the recession that was present. This patient had been through 2 separate intrasulcular tunneling procedure using connective tissue graft and still had a lot of other areas to go, and unfortunately the patient just didn't want to go back. Okay? So it doesn't make sense to do 1 tooth at a time. These patients have thin phenotype. We need to address all of it, and that's exactly what I did for the patient, and you can see the results by comparing before and after, root coverage, okay, as well as thickness gain. You see maximum root coverage, and also when we're looking at the thickness gain, we can see both root coverage as well as thickness gain in these cases. So we can objectively evaluate all of our cases and see we're going beyond the CEJ. And this is the great view you want to look at occlusally to really appreciate the amount of thickness gain that is attainable with Vista. And this is another case where root coverage was not our objective. This patient had a lot of interdental bone loss, so we didn't really aim to cover the roots. Although some level of root coverage was achieved, we can see as we look at pre and post-op, you can see we got significant amount of root coverage in some areas, not 100%, okay, which was not really expected. We got significant root coverage, but the most important thing is the phenotype modification and the thickness gain that goes with each of these cases. Okay, so that is really the most important aspect. We can use Vista for many other procedures. I'll just highlight another procedure using interdental bone loss. Okay, you see this is an intraosseous bone loss. Typically, we would treat this with a regenerative periodontal therapy like a GTR. You see that there's interdental bone loss, and we can appreciate like a 12 millimeter pocket in this area. So the number one complication of these types of procedure is graft exposure, membrane exposure. So by using the Vista technique, we can actually expose our interdental areas, access it for root planing, remove the calculus that was left behind, and coronally position the gingival margin and perform grafting procedure using a sticky graft, this is a FDBA with PRF together, and packing that inside that intraosseous defect. We're using PRF on top of that to cover that, and we can see coronal advancement of the tissues on the facial, and we can see a very fast healing process, and you see we got some shrinkage because of the severity of the interdental bone loss. We had 12 millimeter pocket, and we have a nice amount of bone regeneration in this area. Probing depth is minimal. We could do the same thing with intraosseous bone regeneration around implants. This is a peri-implantitis case. We can appreciate the deep pocket, again, 12 millimeter pocket, suppuration coming from this area, bleeding on probing. So again, if you open the flap, graft exposure is one of the problems. So we are opening this with a Vista technique using a laser. You could use a blade if you want, no difference. Okay, so vestibular incision of the area, subperiosteal tunneling. That's a full thickness tunnel. We can appreciate the dehiscence that's present on the apical areas of the implant, and we expose the crestal intraosseous defect. We could use a laser to also treat the implant surface. This is a CO2 laser that's used on the implant surface for implant surface decontamination. It's really a challenging concept to decontaminate that area. We can also utilizing an airflow to further treat the exposed implant surfaces in the intraosseous component of that. Okay, so this is the airflow to decontaminate the implant surface in the intraosseous areas. And then this is EDTA to remove other types of contaminant that may be removed. And then when we're looking at this, we can appreciate the anatomy of this area where there is gingival margin, implant platform, crest of the bone, intraosseous defect. You see that that's the bone level. So this is the intraosseous portion, and we're utilizing a material. This is a collagenated bovine bone that is placed in this area. But to try to get that into the intraosseous component, you can actually first place it at the crestal area, okay? And then utilize say a curette through the sulcus to try to pack it into the intraosseous portion. We are also placing some graft material in the apical area where there was that major fenestration of the apical area, and we're using PRF as a way of containing the graft material and also promoting a faster healing. And then, but you can see that the incision is sutured, but there's no incisions at the gingival margin or the papillae, so the healing is very fast. We have the intraosseous component that seems to be at least radiographically filled in, which is very useful. So to summarize and give you some take-home messages from our discussion, phenotype modification therapy is the primary outcome for the treatment of gingival recession defect, and also I would say for peri-implant tissue management as well. So peri-implant mucosal thickness affects the peri-implant tissue stability. So phenotype modification for periodontal and peri-implant tissue is extremely important for the stability of these two tissues. So phenotype modification is important for tissue stability as well as aesthetics. Vista has a number of biological and surgical advantages. We're not cutting the blood supply of the gingival margin. We're not cutting the papillae. So those areas have better blood supply, no scar formation at the gingival margin, faster healing. This Vista technique has applications for treatment of gingival and peri-implant recession defects, management of intraosseous defect around teeth and implant. And an application we did not talk about is alveolar ridge augmentation, and many types of application that if we had time we will cover. So hopefully you will look us up on our Instagram page or go to our website learnvista.com. We have a number of courses including the Vista certification. We do that generally 4 times a year. We have a number of symposia with very prominent faculty, a whole number of faculty that we have. If you scan our QR code, takes you to our website. You can see a number of courses with really world-famous speakers on a variety of topics on periodontal regeneration, peri-implant regeneration, alveolar ridge augmentation, really all of them with hands-on surgery, digital workflow, full arch, endo, restorative. Also, we have IV sedation treatment. You can also learn more about the Vista technique. If you go to our QR code, you can see the surgical manual that shows a step-by-step. We hope that you'll join us in one of our upcoming courses. Go to our website, and I'll be happy to answer any questions that you may have.
When do you remove the sutures after doing a surgery?
Okay, the first question was, when would you remove the sutures? Typically, we leave the sutures in for minimum of 3 weeks. So 3 weeks is the minimum, but if you want to wait longer, 4, 5, 6 weeks, or even months, there's no problem with that. That's why we use monofilament sutures that don't wick the bacteria in. So typical is 3 weeks or longer.
How and when do you remove the resin? Do you always use bonding or just resin after you etch?
Okay, so the material that's used in conjunction for coronally anchor bonding of the sutures to the teeth is just flowable composite. We don't need to bond. Flowable has enough, fluidity to, it's not really a filled material, so it doesn't. You don't need to use bonding agent with that. Just etch for about 10 seconds, rinse, dry, coronally advance, just a dab of composite over the knot, and the resin material is removed by just a burr. And once you remove the resin, the suture pretty much separates itself, and then you pull out the ends of it. It makes the suture removal very easy when you have bonded sutures. When you have the sling sutures, it's actually much more difficult to remove, because when you do using sling suture, the suture grows under the tissue grows over it, so it becomes very painful to remove it. The sutures that are bonded, the tips of those are covered by the composite, and once you remove the composite, you just grab the tip and remove it. Now, the vestibular suture, those are like the sling sutures. Those are actually kind of painful to remove. So for that reason, very often we use just resorbable sutures, usually a fast resorbing PGA or PGCL.
To keep the 5 to 6 millimeter vestibule apical space, would you put pressure with wet gauze after the surgery?
So whether you need to apply pressure, I would advise against that. What you would have the patient do is to apply ice, and just the pressure of the ice is adequate. Usually, you don't want to create a dead space, right? So for that reason, if you're putting the connective tissue graft, the dermal matrix, and PRF, that space is filled. You don't really want to compress it, but just applying the ice over the area applies enough compression. Just the light pressure of the ice is all you need to do.
Why not use LePip and LeNap as well with the procedure and technique?
Well, LeNap and LePip are completely opposite of what we're talking about. Because when you're using those techniques of removing tissue, those are both resective procedures, not regenerative, okay? They're resective. You're removing tissue in the hopes that tissue will grow into those spaces, right? So those are open wound healing by removing and excising tissue away. You know, the data is really not available to support those. Yes, there are plenty of clinician testimonials about that, but I would go based on data and not so much based on anecdotal information.
In terms of improving gingival phenotype, how does Vista technique differ from pinhole?
Okay, I'm glad somebody brought up the question of pinhole. Somebody always asks about that. Well, I tell you that my biased opinion, okay, is that the pinhole technique has many flaws in terms of the concept. Number one is by avoiding the incision, using tiny tipped instrument to create the vestibular tunnel. Let me ask you a question. What is more effective in creating the vestibular full thickness dissection and mobilizing the tissue using tiny instruments, or a wide tip instrument of Vista that gets effectively under the periosteum and separates it? The thing is that when you use tiny instruments, you're going to puncture the periosteum, and by doing that, it's going to cause trauma to the periosteum. That's one issue. This more serious issue is the biomaterial that typically is advocated for the tissue augmentation. It is true that I'm advocating biomaterials for phenotype modification, right? But the biomaterial that are supported by data, what I showed you from the Barucci, Tavelli, and Homely Wang's study on phenotype modification and what are the materials that are compared, a celodermal matrix or collagen matrix. These are cell-permeable matrices. These matrices allow cells to infiltrate into them. That's why they're appropriate as matrices for phenotype modification. What is advocated in pinhole technique is a cell-occlusive barrier collagen membrane. Barrier membranes are preventing cells from getting into them. You don't want to use a barrier inside of the tunnel in order to create phenotype modification, because cells will not get into it, and when the barrier resorbs, you're going to be left with nothing. So that, to me, is not an advisable biomaterial to use for phenotype modification.
What kind of burr do you use to remove flowable resin?
The burr that I remove for removing the resin initially is actually a diamond burr. You have to be very careful, but believe it or not, using the blue polypropylene suture is a guide, because when there's coverage with the resin on top of it, as you're grinding that, the bulk of it away with a diamond, you would see the suture, and that's basically your guide to stop. And then you can utilize, there are some finishing burrs that I use to remove the majority of that. What you can also use is a blue flashlight, which is a UV light, that can actually illuminate a composite. You can buy a very inexpensive one from Amazon, and if you dim the lights and you shine that UV light on that, just like the black lights in clubs, it will visualize the residual composite. And if you want to use a polishing, wheel to remove the rest, you could use that. But for most of the time, the finishing burrs are enough to remove the residual material.
We're getting a couple of people asking about the recording of this session. It'll be on our YouTube tomorrow. You can go to our Instagram to see the link tomorrow. The next question is, what antibiotics do you use and for how long?
Typically, the most common antibiotic that we use is amoxicillin for 1 week, to start an hour before and continue for the week. In patients who are allergic to amoxicillin or penicillin type of drugs, typically I prefer azithromycin, 2 to start at 250 milligram, and then continue for a 7-day course. So this is, the typical Z-Pak has only 5 days. I prefer to have a 7-day coverage, so you can prescribe azithromycin in that way.
Couple steps to this. It says, in terms of Vista success for our T2 type and an area that there's active pull-on frenum, if there's scar tissue, if there's a shallow vestibule, if the tooth has a step, what do you do in all these scenarios?
Okay, so those are a lot of different scenarios. We address all of them in our Vista courses, but just to kind of give you a little summary, is that Vista actually deepens the vestibule. Initially, when you're done with the surgery, the vestibule is made shallow, like you're suturing and obliterating the vestibule immediately after surgery. But I can tell you, every single time the vestibule is deepened, and it's not less, it's more, okay? So the vestibule gets deeper, not shallower. With Vista, you do not need to touch the frenum. The vestibule gets deeper by itself because of the attachment that gets to that. It happens every single time. If you go to our Instagram, you'll see several clinical cases, which, as you watch those cases, you will see that in every case, the vestibule is deeper, and we never touch the frenum on the surface. For the steps that are present in non-carrier cervical lesion, just doing a thick graft, phenotype modification without any restorative material is how we manage them.
After harvesting a graft and de-epithelializing it, when you put the side of lamina propria toward the bone or the gingiva?
So the sidedness of the graft is not significant, whether you're using a dermal matrix or whether you're using a connective tissue graft. I think there's no evidence that is present that whether the lamina propria should be facing outward or inward. Typically, of course, the lamina propria is facing outward in a native site, but when you're using as for tissue grafting, it doesn't really matter.
Is it necessary to suture the biodegradable collagen matrix? Will the outcome be affected if we only tuck the material in the tunnel and curl in advance?
When I utilize a collagen matrix, I typically do not suture the collagen matrix because collagen matrices are sticky enough that stays in place. So in those situations, I typically will only position the gingival margin, bond the sutures in the posterior areas, insert the collagen matrix. I don't insert the large one all at one time. I divide it usually in like 2 to 4 pieces and insert them, packing from the most posterior, working forward. And once the material is in, then I put the sutures and bond in the anterior area. The reason I don't bond initially the anterior area is because during the insertion, sometimes you can pop the sutures. So I bond the posterior sutures and then place the material, bond the anterior sutures after that.
What should be the minimal vestibular depth to attempt Vista?
There is no minimum vestibular depth. I utilize this technique for managing shallow vestibule, and in every single case, the vestibule gets deeper. Now, if in certain situations around some implants that you desire to deepen the vestibule, it is possible to perform a vestibuloplasty later on. And there's a technique we call fibrin immobilization vestibular extension. You can look that up in the literature or email us to get that paper to you. The 5 technique is very effective for vestibuloplasty around implants.
Why do you want to keep sutures for at least 3 weeks?
The tissues take a minimum of 2 to 3 weeks to form enough of a stability. You know, the tensile strength of the attachment between the tissue and the underlying bone and periodontal ligament is minimum more than 2 weeks. Because if you remove the sutures too early, the tissues are under pressure and it could relapse. So 3 weeks, I would say, is absolutely the minimum.
Does bonded suture go through the biomaterial? You already answered this. What if those recession surfaces were already filled with composite restorations in the past?
I remove every type of restorative material from the CJ apically, where there's composite, and if there's a crown restoration, if the patient consents to changing the crown, I will remove the crown margin that extends beyond the CEJ. So I want just bare dentin on the roots, and we will try to gain attachment onto the dentin. So every material is removed. I know some of the colleagues are promoting and advising for filling the notches that form with the non-carious cervical lesion. I do not advocate that because I'm concerned that any type of resin that you place over the dentin will have a poor bond strength and will leak over time, and that could compromise the attachment of the tissue over time.
Do you use this technique only for plastic periodontal surgery?
I utilize this technique for so many different types of application, you name it. I've taught this technique to endodontists for apical surgery. I see some of the some of the maxillofacial surgeons have emailed me their clinical cases of utilizing the Vista approach for orthodontic surgery. I've used it for SFOT, surgical facilitated ortho, so you name it. Any type of approach where you can keep the papillae intact and approach in a vestibule manner, it makes it much more convenient.
Can the technique be used with interdental spacing?
Well, the question, I think, means that if you have limited interdental spaces, you have root proximity, that could be challenging, and you have to be very careful. The key is to make sure that you perform scaling root planing and the interdental tissues are very healthy. If the interdental tissues are inflamed, you could separate and the papillae could rip. It's not an end of the world if one or two papillae rip, but you have to make sure they're healthy. Sometimes what I do when I do ortho, and we do very often clear aligner orthodontic treatment, a short phase of it before, and sometimes what I do, I actually create space between the teeth. I separate the roots initially so we have better interdental blood supply, and then perform Vista, and later you can close those spaces.
Can you repeat the name of the periodontal dressing, and do you advise periacryl for the donor site?
I do not advise periacryl. Periacryl, if it gets into under the tissues, it can delay healing, and I find it kind of hard to handle in areas that are bleeding, and I don't think it really stays around too long. Elemental is the name of the material. You can look up Elemental website, and this is a company from Europe that is actually will be shortly available in the U.S. very shortly.
When will the final result be shown? Because soft tissue remodeling takes 3 months.
Yeah, so generally speaking, once you remove the sutures, you have a pretty good idea where things stand. There, you are overcorrecting, and soon after, you see the tissues kind of settling to where they want. So, I think after 3 months is a good period of time. And many times, actually, what we find after 3 to 6 months, you get improvement of that with creeping attachment over the first 2 years. All right, so this has been a really fantastic opportunity for interaction. I appreciate all of you who sent questions and engage in this. That was really exciting. I like the question that you asked. Please look at our website, learnvista.com. You can scan the QR code, go to our Instagram page, connect with us. We would love to hear from you. Email me with any further question or any comments. Please provide any form of feedback, and I hope to see you at one of our courses at the Vista Institute.